Hello everybody, welcome back. Today we're going to talk about the axillary shoulder projection for today's video. So the axillary or the axial shoulder projection is usually performed supplementary to the AP shoulder projection. Similar to the scout Y, it aims to provide a true 90-degree projection to the AP view. Now the aim of this view is to assess for direction of shoulder dislocation and to look at any banker or any other glenoid fossa abnormalities. But the thing is, it's a hard projection to do, and one that isn't regularly performed. As such, it gets hard to know when you've done a good job. Now, this is an example of a good axillary X-ray that I annotated. As you can see, the glenohumeral joint space is open, with both superior and inferior glenoid tubercles superimposed. Now, take note of all the different structures that superimpose with one another in this view, such as the distal clavicle, the acromion, and the coracoid process of the scapula. Now there's a few ways to do this projection, but broadly speaking you can either aim the tube superior-inferior or inferior-superior. Most times inferior-superior are done for trauma patients supine, and superior-inferior are for the more abled patients. With the standard projection, patients outstretch their arm laterally, leaning over the cassette on the table. The tube is then aligned usually 10 to 15 degrees towards the elbow and centered directly onto the glenohumeral joint. For patients who are unable to outstretch due to fractures, the valpial view is an excellent alternative that I personally have used quite a bit. Patients either lean back 30 degrees or you can angle the tube 30 degrees posteriorly if it is unsafe to do so. This technically does not provide that open glenohumeral joint, but it is still useful to assess for dislocations. Now, as mentioned before, inferior superiors are mainly saved for trauma patients or those unable to stand erect, as you can place the cassette on top of the shoulder and reduce OID. Now the Lawrence view is performed with the tube angling 20 to 30 degrees medially or towards the shoulder. Remember to tilt the patient's head away though so you don't get a random skull in your x-ray. If, like the valpial view, your patient is unable to abduct the arm, take the angular suggested a modified technique in which the elbow is raised with a straight horizontal beam. Now let's just say you take an x-ray and it looks like this. The first thing I would say is that's a pretty dang good attempt, and realistically this is how most of mine turned out. But if you do notice, the glenohumeral joint space is not demonstrated open and thus could be repeated. But how do we tell what's superior or what's inferior glenoid? Now my initial thought was to look at any definitive cortical layer difference, much like the skyline patella. However, looking at this AP shoulder x-ray, the glenoid rim is pretty even with its thickness, probably not the best point of reference to use. Now, Lewis this year suggested a very interesting landmark to use, and that's the coracoid process. I'll link her article in the description if you guys want to have a look. Now, let's take a look at a normal glenohumeral projection. As you may see, there is a cortical rim that lines the base of the coracoid process, the one labeled blue here. This is just medial to the glenoid fossa labeled red. As a point of reference, here's an axial CT of the shoulder. Notice again how the base of the coracoid is not on the same plane as the glenoid. By using the spatial relationship, we now have a benchmark to know whether you have angled too much or too little. The base of the coracoid should just be medial to the open glenoid fossa in a good x-ray. So back to our example here. In this case, the base of the coracoid is within the glenoid fossa, and as such is projected to laterally. To change this depends on which direction your central beam is. If you are aiming superior-inferior, you would angle more medial to project the coracoid more medial, while inferior-superior, you would do the opposite and angle more laterally. So, as a recap, if your glenohumeral joint isn't demonstrated to be open, your change of tube angulation would be easiest to correct without moving the patient. Assess your relationship between the base of the coracoid and the glenoid fossa to get a better indication of which way to correct. I'll leave this table here for your reference. But anyway, thanks so much for taking your time to watch this video. If you ever use this technique in practice, let me know how it went. These techniques may not be 100% perfect, and I am curious whether there is any consistency with that gap between the base of the coracoid and the glenoid fossa. But anyway, that's all I have for today. Thanks so much for watching guys, and have a good day.